Good morning, everyone. I'm Dr. Tara Kiran. I'm a family doctor at St. Michael's Hospital and also the Vice Chair for Quality and Innovation at the Department of Family and Community Medicine at the University of Toronto. Really pleased that our department can continue to bring you these sessions every 2 weeks together with the Ontario College of Family Physicians. And I'm going to turn it over to the OCFP President, Liz Muggah, to introduce the session. Liz?
Thanks, Tara, and good morning, everyone. Delighted to be here again on a chilly January. We've got a great session for you. Really amazing that we continue to be able to have these wonderful panelists join us to give us the truth unfiltered and their interpretations and experiences. So they will introduce themselves in a moment. Just a reminder that this is an accredited session, so you'll get information about that in an email after this is over. And I'll just read the land acknowledgement. We acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and DFCM recognize that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. And I invite all of us to reflect on the territories that we're calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. And I'm calling in from unceded Algonquin and Anishinaabe territory. Back to you, Tara.
Thanks. And, it's unfortunate that we've seen, particularly in urban areas, lower vaccination rates among people who are Indigenous and also higher hospitalization rates. And I think, first, because of some of that evidence that folks like Janet Smiley have accrued, the Ontario Science Table has really called out an earlier age for Indigenous people to allow them to be qualified for many of the medications. So I've just highlighted some of those portions there, but whereas for most other members of, most other people living in Canada, it's over 60, but for people who are Indigenous, it's over 50. And then it does depend on the tier, whether that relates to whether being unvaccinated or vaccinated. So just be mindful of that as you're going through. And I think that's, a way for us to recognize, unfortunately, the disproportionate impact on our Indigenous population of COVID-19. Next slide. This is one of a series of talks, and of course, we've been talking about Omicron now for weeks. We do urge you to check out our previous sessions if you haven't, and this session itself will also be on our website, the full recording, usually by the end of the day. So please do share it with colleagues if you get the chance. Next slide. I'm delighted now to turn it to our panelists to introduce themselves one by one. Next slide. And of course, also excited to have our co-host join us today. Next slide. So Elaine, I'll turn it over to you first.
Good morning, everybody. I'm a family doctor in Kingston and Frontenac Islands, so in southeastern Ontario. I am somehow, and you'll hear the story about how I got designated to somehow be one of our COVID leads locally. Before I start, just disclosures, I did get a small honorarium from the Ontario College of Family Physicians to speak today, but no other disclosures.
Thanks, Elaine. Allison?
Good morning, I'm Allison McGeer, and I'm an infectious disease doc at Sinai Health System. I work, as you can see, with a number of the companies that make COVID vaccines and antivirals for COVID.
Daniel?
Hi, good morning, everybody. Daniel Warshafsky. I'm a public health physician and an associate chief medical officer of health for the province of Ontario, and I have nothing to declare.
Thanks. Next slide. David.
Hi, I'm David Kaplan. I'm a family doctor in Toronto and the Vice President of Quality at Ontario Health, and I receive salary support from Ontario Health in my role there and an honorary for the OCFP.
Thanks. Liz?
Good morning, and I've introduced myself already. I'll just add that I'm a family doc in Ottawa, and I receive a stipend for my role as president of the Ontario College.
And I've just listed some salary support and research grants that an honorary that I've been lucky to get, but none of these pose a conflict for today's talk. Next slide. So we're, of course, really delighted to have all of you join us. Right now, there are about 500, and I think we had over 1,000 who signed up for today's session. So we do our best to try, though, and still keep it interactive by answering your questions. So please put the questions in the Q&A, and please vote with a thumbs up on the questions you like the most. If you've been here before, you know that I really try and prioritize the questions that get the most thumbs up. Those are the ones that we'll definitely answer and also generally take up live. So it's better to vote up with a thumbs up rather than type in a new question that's similar to what someone else has asked. If you, though, have resources or a reaction or a joke to tell, please feel free to just put that into the chat. We love interacting with all of you, and I know you love interacting with each other, so use the chat just for that interaction. Next slide. I wanted to, of course, let you know that every time we have these sessions, we take in all of the questions you submitted at registration, and we use them to design the session. So today's session, this is sort of going to be the flow. And I'm putting this out there in particular because I know that many of you have a lot of questions, and we are going to do our best to get to them, but this is sort of the flow of what we're planning. We're going to start with Dr. Ma telling us about her experience in Kingston, which was one of the cities hardest hit by Omicron first, and how primary care has responded. We're then going to turn to David Kaplan, who's going to tell us more about the new COVID clinical assessment centers and what that plan is across the province, what we can expect. We're then going to hear from Allison McGeer, who's going to tell us about the latest for Omicron and really try to answer some of the questions that I put there on the slide that you've put to us. So where are we at with hospitalizations? Who's being hospitalized? How's it affecting kids? What's the latest data on effectiveness of doses? Is a booster still important once you get Omicron? So those are some of the questions that you submitted that we'll try and get to. Next, we're going to talk about Paxlovid and access to new COVID therapeutics, especially those that have to be administered intravenously. We're then going to go into the new testing and isolation guidance. And then finally, we're going to talk about vaccinations a little bit more deeply, where we're at in the province, and just some of the things that we still need to do. So that's a rough overview of the session, but of course, we'll intersperse Q&A throughout that. Next slide. So without further ado, I'm going to turn it over to you, Elaine, to get us started. And Brian, I don't think we need any slides for this.
Thanks, Tara. Good morning, everybody. So I've been asked to talk about our experience here in Kingston, I think partly because it's gone well overall, and partly because we were the capital of Omicron in Canada for a little while there before we shared with all of you. And so before COVID happened, we were fortunate that we had communication between our family doctors, and that we really had one mechanism for being able to do that. And that really helped us get going. Back a couple years ago now, we did have one meeting organized by our then medical officer of health, Kieran Moore, who said, get ready. And at that point, we basically said we need to have a separate assessment center. It sounds like this is coming. It's scary, and we need to not just be counting on our offices when there's going to be different IPAC guidelines, et cetera. And so we said, okay, but we do believe that these patients are family medicine related. So we thought we should be the docs that are staffing it, but we also knew we didn't have the resources to set up a whole separate clinic and staff that, and the funding that's required, and the allied professionals, et cetera. So we formed a partnership. The partnership was between us in primary care, the hospital. It was very supportive. And again, we only have one main hospital, or one hospital that does primary care, and public health. Since that time, we've really maintained that partnership and actually have weekly meetings that I'm involved in. I joke that the way I got labeled to be the physician lead of this clinic was I really put our chief of staff on the spot, and kept saying, well, we'll do this, but you need to give us a space. And he was like, okay, yeah. And I'm like, no, like by next week we need space. Like, if we're going to do this. And so by the end of that meeting, I was designated the person that was coordinating all the family docs, and have just stayed there since then. Our assessment center worked very well, and worked very well in the earlier waves. As we all know, and you've all seen now, that as Omicron hit, and while the testing guidelines were still wide open, we were really moving toward a lot of swabbing, a lot of cohorts, a lot of kids. And we weren't being that effective in assessments because we were booked days out for swabbing. So again, we said we need to do something different to increase our swabbing capacity. And over the course of 24 hours on a weekend, we basically mobilized all family doctor clinics, and there's 24 different family doctor groupings in our region, to have swabs available outside our offices that people could come in, pick up, come to our offices, but not come in, pick up, swab themselves in the parking lot, and drop them back outside our offices. Again, trying to keep this new Omicron out of our offices. That worked really well. And we did hundreds of swabs that way, probably thousands across the region. And then, of course, we all know that the criteria for swabbing changed. And fortunately, at that point, we got to change our assessment center back to what we really wanted it to be. And we'd come full circle. So we'd gone from assessments to swabbing, and then really back to being a true assessment center. Again, those communication between all of primary care really worked well, and we were able to send out a message that's been consistent. So if anybody has respiratory symptoms, it's been pushed out through social media, it's been pushed out through our offices, and certainly our secretaries play a great role in this. When people call, we give them different options, and it's 4 to 5 options depending on the clinic. One is simply self-isolate. You've got minor symptoms, you don't need to be seen by a physician, just stay home for the 5 days or the 10 days, whichever the case may be. Second is set up a virtual appointment with your family doctor. Many of us are on OTN, some people are doing phone appointments, and sometimes that's enough to give somebody that reassurance that they need. But we all know that virtual doesn't replace in person. So certainly some offices in the more remote areas of our region are doing in-person assessments for these patients with suspect COVID. But we also recognize that for many offices, that was a really scary option. We don't have great, huge waiting rooms. We don't have all the same IPAC that our bigger facilities have. And more importantly, we still really want to be able to see our vulnerable people, our people that are immune compromised, that have other comorbidities, that need to be seen for completely non-COVID related issues, but we want to keep them safe in our offices. So what we're doing is, in most cases, in most offices, other than, as I said, those more remote ones, if we either the patient identifies right from the start, no, I need an in-person assessment, or after we have a virtual assessment with the patient, we say, no, they need to be seen in person. We're referring them over to the assessment center where they're able to get in same day. Those appointments are only open same day or the day before, and they're able to be seen there. Some people get swabbed, some people don't based on the criteria, but everybody is able to book in to see the physician there. And we've got those staff with the family doctor. Only in the most serious instances are we sending people over to emerge initially. So those would be people that call up and say, you know, I can't catch my breath, or I have active chest pain. But we do know that we identify some people at the assessment center that need to be seen in more than our big yellow gym, as we affectionately call it. And we send those over to emerge, and we've got a really good working relationship with our emerge department in the community, where they know that we can't do everything in our big yellow gym that we might even be able to do in our offices. And so those people are getting sent over to the emerge department, and we've got a really good communication network there. Has it been perfect? No. Are there bumps along the way? Absolutely. Are our assessment centers put more demand on our family doctors? Yes, because we're asking everybody to staff these shifts. But by and large, I think we're overall really happy in our community. And I think our community is really happy that we've got this alternative place. And at the same time, we can keep our doors open for other things.
Thanks so much, Elaine. I mean, you've been really an incredible leader in Kingston. I know you've talked and focused, thanks to, you know, as we've asked you to, on testing, but you've also done an incredible job with vaccinations. And what I've really loved hearing about the testing assessment model is the integration from the front door, our clerical staff, and the messaging, you know, that they're so importantly have to convey to patients. And then all of that, all the way from the office to the clinical assessment center, to the ED, and kind of really thinking all of that path through in an integrated way. So I know it's something that is tougher to do in a big city, I'll say, I think, to have all those parts talk to each other. And it's amazing and inspiring to see that you've done it in Kingston. So thank you for sharing that with us. David, I wonder if this would be a good time to turn it to you to, and maybe Brian, could you bring up David's slide to just talk a little bit more about the provincial plan around COVID clinical assessment centers?
Perfect, fantastic, yeah. So for the last, I don't know, 19 or 20 months, I've taken offense to the fact that we've called these COVID assessment centers, because really they've been historically COVID swab centers. Very few of them were doing true assessment, and with the pressures on our emergency departments and other places, we were able to move the needle and really try to stand up true clinical assessment centers for people who, you'll see in a minute, need a clinical assessment given their symptoms. So if you go to the next slide, Brian. So the goals of the clinical assessment model are really to conserve capacity in the emergency department and improve patient outcomes. Not just patient outcomes from the standpoint of patients being able to access care and be reassured that they don't need a hospital visit, but for patients who are appropriate, make sure that the oncoming therapeutics are able to get to them in a timely manner. As many of you know, the therapeutics to date, sotrovimab, budesonide, Luvox, all require being started within 7 days of symptom onset, and Paxlovid, which is coming to Ontario, requires starting within 5 days of symptom onset. So really important to get the right patients assessed and see if they meet criteria for therapy. We also want to make sure that we can provide patients within an expanded scope of clinical services. And so this is what I was sort of getting at, the difference between just a swab center and somewhere where people can actually get an assessment if they can't get one in primary care for a variety of reasons. And that really speaks to the fact that these assessment centers are actually not meant to replace the care that some of us are able to provide in primary care. Rather, if we do speak to somebody on the phone or see them in the office with suspected or confirmed COVID-19, we can refer them to these places to be examined in person if we feel that we can't safely see the person in our own clinic, or if we don't have access to an oxygen saturation monitor, for instance, in our office, and we're worried about the patient's clinical status. The other piece to this is that these do not intend to replace the volume seen in our assessment centers for swabbing. And rather, these are really an augmented model to the current assessment swab center model. Next slide. So that really the key messages for primary care is first, and I know Sasha has said this when he was on with me previously, is that the family physicians, nurse practitioners, other primary care providers have really been a key partner. We really want to speak against that narrative that primary care is not sort of pulled their weight during the pandemic. We know that that it has a sector that is a key partner in so many aspects of the pandemic response, and it is deeply appreciated, I know, by our whole executive team at Ontario Health. In response to Omicron, as many of you heard, we've really asked primary care to prioritize three things: urgent and emergent care for your patients to avoid ER visits, supporting vaccination, which I know many of you continue to do and did it over your holidays, and also, if you can, remote monitoring for COVID patients. And we know that thousands of family physicians and nurse practitioners since December who hadn't done remote monitoring before have actually ordered O2 saturation monitors for their patients. I know some of you may be waiting for yours. We're waiting for the last 3,000 monitors to come in. And as soon as they're in, we will get those out to you. But we were able to get another 10,000 monitors out over the holiday period. These clinical assessment centers that we talked about are really an additional resource to help us divert our patients from emergency departments if they don't truly require emergency department care. Next slide. So there's really four standard elements to these clinical assessment centers. The first is patient identification. So these are really for patients with either known or suspected COVID-19 with worsening symptoms or a pattern of symptoms, or they've been advised by their health professional, a nurse in our office, ourselves, that they require an in-person assessment. This is because their symptoms can't be safely monitored at home. You can imagine the patient who has multiple comorbidities, or a patient who seems to even be short of breath on the phone, but they're not experiencing severe enough symptoms that require emergency care. So obviously, if you're really worried about somebody, it's still appropriate for them to go to the emergency department. Patients who meet criteria should be directed to these assessment centers, and they can also be directed by themselves. So walk-ins, depending on the local context, may be limited. Telehealth may send them, we may send them, an emergency department may send them. So somebody may present to triage in an emergency department, and many emergency departments are looking at actually diverting these visits to a clinical assessment center. Or if there's an assessment center that's offering testing only, they may feel that a patient qualifies to be seen at a clinical assessment center, and they'll be redirected there. The other piece is patients who are at risk of severe disease. So many of you have seen the new, I think it's been updated now 3 times in the last couple of weeks, the Science Table Advisory sort of 2-pager on who's eligible for outpatient therapeutics. So that's oral antivirals like Paxlovid and monoclonal antibodies like sotrovimab. And patients who are at higher risk of disease. So if a patient calls our office and they're unvaccinated and they're 70 years old, it's absolutely appropriate to send them to one of these clinical assessment centers so they can get tested, either with a rapid test or a PCR, and get started either on monoclonals or other therapies, depending. So this is really, it's really important, that message needs to change, that, if you are unvaccinated and if you're older or you have comorbidities, if you're really at risk of developing severe disease, we want people to be seen at a clinical assessment center. Next slide. So the assessment at these centers could be assessed by a whole variety of different health professionals, depending on the geography and what's available. It could include, like I mentioned, vitals, oxygen saturation, seeing if people qualify based on risk factors and comorbidities. And they could be tested using a rapid test if appropriate. It could be an ID Now PCR test that are being, we do own those machines in the province. The diagnosis, however, needs to be determined and communicated by a nurse or a nurse practitioner. And then really the discharge planning, which is going to be based on guidelines, expertise, and judgment. And that could be either self-monitoring, hooking them up with a local remote care monitoring or COVID at home program, possibly being sent to the emergency department if people feel that they need further investigation, blood work, chest x-ray, and the like. Possible direct admission to an inpatient unit to avoid, those COVID-19 patients who are sick having to wait and emerge. And then, as I mentioned, directing them to outpatient therapeutics when appropriate. Next slide. You'll see, I think I'm not following the chat while I'm talking, but you can see there's some links here to that guidance that I believe my colleague Janine has been mentioning in the chat. And this is really how to figure out who the target populations are. We've been working with the Center for Effective Practice throughout this process over the Christmas period to design this guidance. And this is just a slide that sort of just highlights everything I said on one slide, with some links to the eligibility for COVID therapeutics, and then some guidance around target populations. So maybe I'll stop there, and I think that's the last slide.
I think there's one more slide.
Is there one more? Yes.
It has the link at the bottom as well.
Oh, there it is. Yeah, that's the actual link to information for primary care providers that we did with the Center for Effective Practice. One other thing I probably should add, and we were hoping to get the details, but we've been really slogging away at this, is actually getting a separate requisition for primary care providers to be able to order PCR tests so that we can initiate COVID therapy. As soon as we have that pathway sort of sorted out with the ministry and our partners, we'll make sure that we get that out via the OCFP and the Center for the OCFP and the SGFP and others, so that people know how to get the referral form and order those tests.
Thanks so much, David. And just to clarify, if you're using oral medications or the inhaled medications, I don't think you absolutely need to have a confirmatory test. And the science table, I think, is fairly explicit about that now. What you do need to do, though, is check drug interactions, because fluvoxamine has many of those. And so we'll talk about that in a moment. And maybe I'll just take a prerogative to just ask David, do primary care get communicated to when somebody is seen at one of these COVID clinical assessments?
Yeah, so I think if you went back one slide, I sort of glossed over it for time, and maybe I shouldn't. So thanks for highlighting. In the top right of the last slide, it does talk about communication back, handoff back to the primary care provider. And if people don't have a primary care provider, a number of options. I know some of our family health teams actually for quite some time now have created like a virtual family health team so that people who don't have access to primary care are hooked up from the COVID assessment centers to primary care and help them try to navigate finding a new family doctor as well. So using it as an opportunity for attachment.
Thanks.
Maybe. Sorry, Tara, I just wanted to jump in and just say, one of the things I think that's important to comment about is we're all trying so hard to work as a system. And I really would call out Ontario Health. They've been good partners with us in family medicine and sort of really trying to map out, like, it's not straightforward to try to pivot from swabbing into assessment and who should go there and what does the flow look like, what's patient-centered, what considers the work that we're doing in family medicine in terms of getting patients there and then bringing them back. And so, just to call out that I am grateful for that. And, these things are a work in progress. We're, as I like to say, flying the plane and trying to change the wheels at the same time. But I think, thanks to David and the team behind you for making sure that we're a clear part of that pathway. So
there was a question, thanks Liz, there was a question I see in the chat about how quickly people get oxygen saturation monitors. So if you order them for your practice, they're being shipped to you, not to your patient. For many of the remote monitoring programs, they are shipping them to the patient like the program is. So if your local hospital, for instance, has a remote monitoring program, they're often couriering like same day the oxygen saturation monitor. So it's very different depending on what model of care. For people, like I know in my practice for the patients that we've been looking after in COVID at home, what we've typically done is either one of the docs has dropped it off at the patient's front door, or we've had a healthy family member who's not isolating, a cousin, a relative, whatever, pick it up from the office and drop it off at the patient's home. So it all depends how you've sort of set up your remote monitoring program in your geography.
Yeah, so I think Janine has also answered that question. I think there is a question about where these are, and I'll just say I think that's actually on the CEP website. So if you go onto the CEP website, you can see that. I know that somebody posted that they think their COVID cold and flu center is not actually listed there and should be. And so maybe David, you could just take note of that and follow up if needed. Also wanted to call out a couple of important comments. I mean, I think Maggie Karastecki was saying, how grateful she was for the support of primary care, especially for someone who's hurt, like a caregiver at home and feeling fairly isolated. So just that, we are obviously playing an incredibly important role for so many people. And the other, I think batch of comments that we're talking a lot about access to treatment, but there are limited numbers of there's a limited number of these drugs. And so unfortunately, this is not going to be the answer to get us out of this wave, and it's only going to be helpful for a select number of people. Really increasing vaccination rates and focusing on all of those other public health measures is how is going to be more important. So yeah, it's frustrating. I think I can see that in the chat that we all want to prescribe these medications, but there are limited amounts. Next slide. So I know that Allison and others and Daniel and others have been busy answering questions in the Q&A, and I'm definitely going to take those up live, some of the most common ones. And I think Allison is going to probably speak to some of them when she talks, but I do want to make sure we give time to Allison before we answer some of those questions. And I think a lot of us have on our mind, where are we right now? And of course, we know we can't really trust those case numbers, which look like they've kind of peaked and come down. It's hard to know if we can trust them because of the really limited test number of people who are able to get tested. I think what we're really keen to watch is that hospitalization rate and where are we? And it's hard to say whether that's going down as yet, I think. So I'm going to turn it over to you, Allison, to give us some insight in terms of where we are. Next slide.
Thanks very much. Okay, so let's start, because people asked about the updated version of vaccine efficacy and third dose efficacy. These are data from the UK, right? All our best data come from the UK, even though they're not doing as well as us in terms of controlling disease. So, you know, there's everybody has their weak points and their strong points. So in the UK, these are data from people who had 2 doses of Pfizer, and the base 2 doses of Moderna looks very similar. With either a Pfizer or Moderna booster, the black squares are Delta, and the circles, the gray circles, are Omicron. So you can see as the weeks go by post second dose, protection against Delta wanes to about 60% at 6 months post-vaccine. This is and this is any infection. But with Omicron, it wanes down to about 10%. So really 2 doses of vaccine against Omicron does not provide you with good protection against any infection, okay? Coming back to serious infections in half a minute, okay? You get your 3rd dose, okay? Get your booster dose, you bounce your protection against Delta back up into the high 90s. You bounce your protection against Omicron back up to about 60%, okay? Not miraculous, but a lot better. And that's why we're working so hard at getting 3rd doses out to people, why 3rd doses are going to make a significant difference to transmission. I think one of the real concerns at the moment is that our 3rd dose rollout really seems to have stalled. And that's I think a natural reaction and a pleasant reaction to Omicron. Is not as bad as we maybe thought it was going to be. But still, in order to preserve our healthcare system, in order to get us back to normal, we are going to need to really get our backs into getting 3rd doses out to more people. Next slide. Sorry, next slide. Yeah, okay. So now here, just on the right-hand side of this is vaccine efficacy against hospitalization, which the Brits can give us. Again, you're looking down at dose 1, dose 2, and dose 3, and interval after vaccine. And you can see that protection against hospitalization with 2 doses in the UK for the first roughly 6 months is 64% against Omicron. Get your 3rd dose, it boosts up to 83 to 92%. So one of the questions in the chat was, are we seeing triply vaccinated people in the ICU? And the answer is yes, okay. Vaccine is not 100% effective against, even 3 doses of vaccine is not 100% effective against hospitalization, but it's significantly more effective. So the rate of ICU admission in people who've had 3 doses is significantly lower than the rate of ICU admission in people who've had 2 doses. Again, really particularly for those of us who are on the wrong side of 50, a really good reason to get your 3rd dose of vaccine as soon as you can. Next slide. And here's the Ontario science data where you can see this, okay? So this is vaccine protection against ICU admission in the orange, hospitalization in the yellow, and any disease, which is sort of blue. And just you can see that as Omicron comes, vaccine protection drops a little bit, but you can also see that the blue line is rebounding, and that's not actually rebound, that's 3rd dose effect. Okay, so not very many people who have 3rd doses. Now we have a lot more. And so you begin to see the case rate going down most dramatically, and the hospitalization rate and the vaccine efficacy in hospitalization and ICU going up a little bit. That's 3rd dose effect measurable in Ontario. Next slide. Okay, now I put this slide up to talk about where we think we're going. If you think your last 2 weeks have been miserable, meet how the modelers have felt about this, okay? Because we've all really been concerned about, where we're going and what's going to happen to Omicron. And they had the rug just ripped from under their feet in the week between Christmas and New Year's when we lost case counts, okay? We got really used to case counts being the foundation of how we were predicting what was going to happen. The modelers got really good at it. We had, just awesome data about what was going to happen. And suddenly it's just gone, okay? So we're going to come back to see that dip down. So this is modeling from the federal modeling table about a week ago, suggesting that we might be past peak and things are coming down a little bit. Next slide. And this is, in fact, a cobbled together new set of data, okay, which is everywhere you think you might be able to get data that will tell you what's going on. So it starts with wastewater surveillance. Wastewater surveillance has finally come into its own. It's been like running quietly in the background, and it's been really useful, but we haven't really needed it. But now we need it, okay? And looking at what's happening in wastewater has been very useful in thinking about what's going on. People are starting to look on, there's some hospitals that are screening all surgical patients when they come in, or all patients in labor when they come in. That gives you some base rates. People are looking at absenteeism. There's a whole set of new data that modelers are looking at to try to figure out what's going on. Because it's new, it's still really hard. Because some of the data like hospitalizations are delayed, it's not easy. So modelers are still really substantially uncertain about what's going on. But I think the consensus now is that we're seeing the effects of the public health measures that were put in at the beginning of January and the third dose rollout that is happening. And from my perspective, okay, non-quantitative, okay, so not that helpful with modeling. If you think about it, in Toronto, we've got fewer new long-term care outbreaks. The number of staff long-term care cases is flattening. The hospitalizations are rising more slowly if you look at them. People are not in as much of a staffing crisis as they used to be. Let's say there isn't a staffing crisis, but it's a little better than it was, okay? And if you're an infection control person and you live in Toronto, you can now look at the COVID line lists from Toronto Public Health of how many outbreaks there are, the way you look at them during flu season, okay? In flu season, fundamentally, if the Toronto Public Health line list is longer than 2 pages, flu season is starting. If it's more than 6 pages, we're at peak, okay? Really simple way to do surveillance, okay? We're on 23 pages of COVID outbreaks, okay? So that tells you that this is bad, okay? But we're stabilizing at 23 weeks, okay? So everything is telling us that we may not be decreasing, okay? I think there's some argument among modelers about whether things are actually decreasing or whether we're plateauing. Either way, it's good. Now we've opened schools, okay? And opening schools are going to put a bit of pressure on transmission, okay? We agreed we wanted that for the benefits of schools, right? It's not that opening schools doesn't provide some little bit of extra pressure on transmission. It's just that it's really important to do that for the health of kids. So opening schools is going to put a bit of pressure on. And then, yes, I see in the chat, people are saying, what do I think about the restrictions? You don't actually care what I think about the restrictions, but you do care what the modelers think about restrictions, which is, okay. So yeah, I think everybody is extraordinarily anxious that the restrictions are going to get us into trouble again. And I'm hoping that maybe when the modelers get their data out to politicians, that will change our mind about some of it. But it's going to be what it's going to be. Next slide. Okay, so just to point out, this is not, again, this is not a mythical wave of Omicron that has decided to come and go by itself, okay? This is a wave of Omicron that we are manipulating with vaccine and public health measures, okay? The reason it's getting better is because more people are getting third doses, and public health restrictions are working. And I think we can be reasonably happy. I can't see the bottom on this slide, but I think it's about 80%. So people who are over 70. We've got third doses into 80% of them, which is pretty good. Here's our big gap now for control of Omicron transmission, that we really need to move out third doses to younger people, so that we can, again, this is more about getting us back to normal for 20 to 30-year-olds, as opposed to preventing hospital admissions. But still, you know, young third dose people who get COVID transmit to unvaccinated older people, right? And so it's the herd immunity that goes with vaccinating younger people that's important to us. Next slide. And you can also see the effect. This again is from the science table about high risk mobility indicators. You can see that the public health measures that got put in place at the beginning of January are having an impact on high risk activities. You know, the contacts are going down, and so that really is working. And so one of the reasons that I know that this is public health measures is that one of the things that's happened in Ontario is that influenza has disappeared again. Okay. Prior to January, influenza was on this slow creep up in Ontario, much less in the States, but still very clearly increasing. Looked like maybe we were going to get a flu season sometime in February if we didn't do anything. And since January the 4th, vanished. Okay. So if I had told you before the pandemic that the kind of measures that we are sadly getting used to now would completely stop flu transmission, just think about this for a moment, that we could prevent like 3,000 deaths in Canada if we were just willing to do this every winter. And I'm not suggesting we should be or we're going to be, but it's really quite remarkable that public health restrictions have this impact on seasonal flu transmission, which we thought was impossible, right? Pre-pandemic. Anyhow, so yeah, things are definitely getting better now, and we'll just have to see how we do as we try to, again, run this balance of easing restrictions and allowing our healthcare system to function. Next slide. Okay, so some bad news about rats for Omicron. These are data from a study from Switzerland posted a few days ago in medRxiv. And what you can see is that the sensitivity of PanBio, which was about 68% for all testing for Delta and 85 or 90% for high concentration Delta, has dropped to about 36% overall for Omicron. Okay, so that does not mean that rats are useless. Okay, a positive rat in the current setting has a really high positive predictive value, tells you that you have COVID. And even if we only detect 40% of people with COVID, okay, that's a lot better than nothing, okay? But what it tells you is that a negative rat is not worth what it was worth in Delta, okay? So we just kind of need to reorient ourselves and really reinforce the fact that a positive rat is definitive at the moment, but a negative rat is not as useful as it was for previous variants, and we just need to live with that. Hopefully, this presumably has to do with the structure of the nucleoprotein antigen in the lateral flow tests, and I can imagine that the people at Abbott are really working hard to try to get something that'll work better. ID now seems to be holding up for those people who have access to it at hospital sites. So we can hope that this will get better, but it is going to take a little time to get better for sure. Next slide. Okay, and then let's end on Paxlovid. This is a pathogenesis or a mechanism of activity for molnupiravir and Paxlovid. Remember, when viruses get into cells, they make long polyproteins, and viral proteases then chop those polyproteins into individual proteins that are used for RNA replication, both for the RNA to make structural proteins for the virus and for the RNA that's going to go in the RNA genome so that you can reassemble the viruses and get them out of the cell. So proteases, these proteases are common targets in viruses. Lots of proteases, as you know, for protease inhibitors for HIV. There's protease inhibitors being developed for influenza, and the active ingredient in Paxlovid, which has a long number, is a protease inhibitor. It's combined with ritonavir. The goal of the ritonavir is to keep the levels of the protease high enough for long enough that you can give it twice a day instead of having to take it 6 times a day, which would be seriously annoying. But the problem with ritonavir, of course, is adverse events and drug-drug interactions. In case we ever get molnupiravir is a nucleoside analog, so it inserts itself into the RNA and causes cell death because the RNA is no longer effective. Next slide. I think we've set a new record for kind of absence of solid evidence and EUAs, which is that we still haven't seen any of the published data from, and I apologize for the slight mess on this slide. This is Allison getting her slides to people at the OCFP way too late. You know, we have no published data. We have only press releases, and those press releases say that Paxlovid, if given within 5 days of the onset of therapy, is about the same as remdesivir given 5 days beyond the onset of therapy, which is upwards of 80% reduction in hospitalization and death. It has clear disadvantages, particularly in places like long-term care. It's got to be within 5 days to be useful. You can't crush the pills, can't use it in people with renal failure, got a ton of drug-drug interactions. So for people on medications, in an ideal world, you want an HIV pharmacist who's used to thinking about ritonavir contraindications and can zip through them for you. And the GI side effects of ritonavir, nausea, abnormal taste, diarrhea, they're not catastrophic, but they're kind of unpleasant. And so it does have some limitations. The big limitation, however, as Tara has already pointed out, is we just don't have very much of it. And because we don't have very much of it, it's going to be really hard for people to try to use it where it's most effective. And I think imagining that we're going to achieve, equity or complete fairness across the province in the next month is just dreaming in Technicolor. We can't do it. Mostly, I think what I'm hearing from the hospital hubs that are doing this is that it's being reserved for people who are immunocompromised. You can clearly see that seriously immunocompromised people have substantially increased risks of hospitalization and ICU admission. And so that's where our sotrovimab and our remdesivir and now our Paxlovid will likely be mostly directed. And that honestly will probably soak up most of our supply for at least the next month. After that, it will get better. And, as we practice with this, we'll also get better about getting it out to people. And I think that's the end of my slides. Thanks, everyone.
Thanks so much, Allison, for that whirlwind. So much that you covered there. I'm going to actually go to the next slide. The next slide is just a screenshot from the updated guidance from the Ontario Science Table. And, to Allison's point, we have a limited supply of all of the medications. And I think it makes it even more important that we really try and risk stratify who it is that we give the medication to, whether we're talking about, the IV medications, but also the oral and inhaled medications. I think I personally find this one pager a real great go-to, and it clearly outlines on the tiers, who you should be thinking about. Next slide. And they have now also put out a one-pager on fluvoxamine. So that's put out by the Science Table and the University of Waterloo School of Pharmacy. And this is might be extremely helpful to many of you on the call who will be prescribing this. So I'm going to actually just end slides and ask maybe David and Dan, whichever one you think could speak to this, just about accessing the IV medications and what's the plan is for that, which centers are open at this time, and how can family doctors refer to them?
Dan, I don't know if you have any comments. I mean, so family doctors, there should be 7 centers that are open. Right now, different centers have different referral forms. So St. Joe's has a referral form. I'm not sure if Scarborough, for instance, has a referral form yet. About 10 days ago, they didn't. I just sent a note to oh my goodness, the General Internal Medicine Clinic. But there will be some guidance that comes out with explanations. You definitely can call one of the assessment centers that we posted. I posted the memo that just went out. I know the OMA also sent it out this morning with all of the addresses. So not just the names, but the addresses and the hours. These assessment centers, should be able to get your patients therapeutics if they qualify. So it could be an extra step, but we will get another memo out, I can tell you, about IV medications and Paxlovid in the near future.
Do you have anything to add there, Dan? Especially also even about the centralized or one referral form, or where we can find more information?
Yeah, not much to add. As David said, it's coming in terms of a plan, and it'll include not just the IV medications, but kind of broadly including Paxlovid antivirals, like how to access COVID therapeutics in the outpatient setting. And hopefully that'll clarify things when it comes out. I think it's planned for sometime next week.
Yeah.
Okay.
I think the plan is for Monday, I believe. So.
Great. So in the meantime, I think trying to connect with an assessment center sounds like a terrific option who can redirect you to the right place. I can
see, so Humber, I'm just looking at the chat, Humber does have a referral form now, and Cleo Lang has said that Scarborough has one as well, so.
Yeah, and I think Toronto, I think HRH and the Ottawa Hospital do too as well. I guess I'm not clear on whether there's a central place for all the referral forms, but doesn't seem so. Maybe that's something that the Center for Effective Practice can take up and put on their website in one place or somewhere else. I'm going to just take a moment to also ask Allison some of the kind of questions that have been percolating in different forms. So one of them that seems to recur is, and Dan, feel free to also jump in here, relates to how long people are infectious for when they get Omicron, and what the implications are for that in terms of doing the test and test positivity.
Yeah, so a really difficult question to answer, because I think there's multiple things going on here. So triggered by people saying that we could change the cutoff of risk from 10 days to 5 days. And a piece of that, I think, was that we were hoping, because Omicron has a shorter serial interval and looks like it has a shorter incubation period, that might mean you were infectious for a shorter period of time. I think I agree that the evidence is evolving that says that people are probably not infectious for a shorter period of time with Omicron than before. Having said that, we're also at this stage where, with their doses of vaccine, disease is a lot less severe. We are talking about, moving to fewer restrictions and allowing some greater degree of transmission. And so the 5 days is, we're not using 5 days in healthcare, right? We don't want people back. But we are facing staffing crises. Okay, so now imagine that you're completely stuck on staffing in a hospital or a long-term care home, and you've got a choice about who you can bring back. You can bring back somebody on day 6 after they've had COVID, or you can bring back somebody who's got a household contact and has been exposed as an asymptomatic. And when I look at that balance, I say, yeah, some people who are on day 5 after the onset of COVID are probably still infectious, but they're almost certainly much less infectious than they were immediately before they got disease, or on the first day or 2 of symptoms. So yeah, I'm still a little worried about them. I just as soon not have them taking care of transplant patients or, very frail elderly people. But they're probably not very infectious, particularly if they're, following the rules about masking and social distancing. I'm not that worried about them. A household contact, on the other hand, is like, geez, they may not be symptomatic, but, household contact transmission in Omicron is running 60-70%, right? So I'm really worried about those people, even though they're asymptomatic and I don't know they're positive for COVID. So my view of the 5 days is it's not an unreasonable balance. Yes, some of those people look like they're still shedding virus. No, in an ideal world, I'd like to have them at home. Maybe not until day 10, maybe until day 8 or 9. But if they have to be back for some reason, it's probably okay. So this is, in some senses, we're hitting the hardest part of the pandemic in terms of making decisions, because we have to move from we can't have transmission because too many people die, okay, March 2020, October 2020 for that matter, okay, to this is a seasonal respiratory virus and we're living with transmission and with the disease, and that getting from here to there, okay, is going to be kind of a long, slow pathway with a lot of these like really hard balancing acts in them. Same with, I saw a question about retirement homes and, what we're doing with precautions in long-term care and retirement homes. We're facing those same really difficult decisions about what now the right balance is between the harms of COVID, which are becoming substantially less as we get more vaccine into people and have more people infected, and the harms, then the collateral damage of prevention measures for COVID. So, nothing is easy anymore.
Thanks, Allison. That was like a really comprehensive answer. And I think also answers, I think I've just reiterate some of the things that I've also seen you type is that, generally people are not infectious after 10 days. So if you continue to have a rat that's positive after 10 days, that's not indicative of any kind of continuing COVID. Similarly, a PCR test can be positive for weeks after COVID, and that doesn't mean that you have COVID still. So after 10 days, you've recovered and you don't need to be worried. I think the one exception now is people who are immunocompromised, who might take longer. And I'm going to just actually, Brian, would you be able to put back the slides? Just I wanted to make sure that people know about this new guidance. And the new guidance, and Dan, you can speak to this. There's a rationale, I think, for now lengthening the, so we'll go to the next slide. So this is just in case you didn't know, I think almost everyone on the call would know this, that there's been a change in PCR testing eligibility to allow certain other groups, including household members of people working in highest risk settings, people who are pregnant, and others that we've put on this slide here, first responders, temporary foreign workers, and congregate living situations. So you can refer to this slide after the webinar. Next slide. But what I wanted to draw attention to was just this new recommendation that there is now a 20-day isolation recommended for people with severe illness. Next slide. So who does that mean? Severe immunocompromised. So people who are severe immunocompromised are people that have the conditions listed here. And in terms of medications, that's pretty much anti-B cell therapies and high-dose steroids, not the methotrexate or antimetabolites is my understanding. And Dan, I wonder if you wanted to speak to kind of that rationale.
Sure, I can quickly. Thanks, Tara. As Allison already said, we know that people who are severely immunocompromised or really, really sick in hospital, they're taking longer to clear. They're having symptoms for longer. They have an ongoing higher viral load, and so this isolation appears to take that into account. I know we've got a lot of questions about who is that severe immunocompromise and how do you break that up, given we've had multiple definitions of immunocompromise over the course of the pandemic for different populations, but it's really the people who have a very, very poor, low immune response to the vaccination if they've had it, and difficulty in actually combating the infection, which is these highest risk groups that you have here. And I think that the most important, as you noted, is for being considered immunocompromised for the vaccine purposes, it's that extremely broad range of medications, basically anybody on anything that might be even mildly immunosuppressing. But when we're talking about severe immunocompromise for the purpose of isolation, it's not the person on their stable low-dose methotrexate, it's high-dose prednisone, B-cell therapies, the ones that, if people remember back to August, that were very, very first eligible for those additional doses.
Thanks. I'm going to go to the next slide. And just a reminder that our session is going to continue until 9:15 because I know that people have a lot of questions. So there have also been in the latest guidance released Jan 13th that there's a lot of clarification about what to do around case and contact management. And, I think a key piece is that the household contacts that Allison said are at high risk and they have to isolate for the entire period that the case is isolating for. If someone in the household gets infected while they're isolating because they're a contact, then so there's case A, and then the family isolates with them at home. Someone in the family, though, then gets positive. Everyone else has to restart their clock again around isolation, except for the case A that was original, who can stop ending their isolation as directed due to their symptoms. And so hopefully that was clear. It might not have been, but it's hopefully clear on the slide. And I think one of the questions that people had as well, and I'll ask Allison and Dan here, because if somebody has had Omicron, how do these isolation guidances change or differ? And so let's say, person A got Omicron, their whole household then isolated with them. But then, a month later, someone in their household became positive. Does case A have to isolate all over again? Now, my understanding of the guidance is yes, they do, but I saw that there was maybe conflicting, or maybe the panelists weren't all in agreement. So I wanted to just raise that because my understanding is that the guidance says that you're supposed to behave as if you were a fully vaccinated person in respect to the guidance once you have Omicron.
Yeah, I can start with that one, Tara. So I think you've got it right. So I think best things that this is gray in the current guidance is probably the best explanation. The only thing in the Ontario guidance now is, as you said, if you have had COVID since December 20th, you'd be considered equivalent to fully vaccinated. But fully vaccinated people still have to isolate if someone in their household has COVID-19. To Allison's point from before, we know you have a little protection from it. You're not going to get it sometime very soon, but it's not currently addressed in the way the guidance is written. So I think, the best thing would be, like you said, Tara, if it's part of the same episode, you were a case and the next person in your house, there's no need to re-isolate. But if it's 2 months later, since the last infection, probably at this time we'll be saying that you should, because we really don't have the data to show what's the right number of when you're protected until. I don't know what you think about that, Allison.
Yeah, I think, I think it's really not going to happen often enough that it's become a major issue. So I'm not that worried about it, but I do think that if the Omicron wave is going to go on for another 2 or 3 months, it probably is something we need to think about, in part because we're going to continue to have staffing issues. And, if you got Omicron, it's less of an issue in household contacts, because the introduction of Omicron twice into households probably not going to be an issue at all. It may be an issue for healthcare workers and long-term care workers, where you might end up having to put people off, and that's a circumstance where I think if we don't get Omicron to settle in the next few weeks, we might want to think about it, because suggesting that somebody who's had, just had COVID and has been re-exposed at work should be off again probably doesn't make a lot of sense in the setting of staffing pressure we're on. But I think at the moment it's not a sufficient issue that it matters very much. I do want to say one thing about sort of the 10-day period. One of the things that happens to some people who get COVID is they get really frightened about them posing a risk to other people. And when you say, you know, after day 10, it's okay, many people are kind of scared to go out and have contact with people because they might still be infectious. So it's really helpful for those people that were definitively clear about the 10 days. It's like, after 10 days, you're fine. You can go back to normal and doing everything that everybody else is doing, because really for a significant proportion of people, it's really scary to think that you might cause infection in other people, and drawing the line at the end of it and saying I'm not at risk to other people is really helpful to them.
Thanks, Allison. So I'm just going to go over a few things now that might answer people's questions further. Next slide. And I also wanted to just thank Andrea Chittle for some of these slides. So the next slide is an algorithm that she's put together to kind of help people around some of these questions that are coming in through the chat, or that people are confused about, you know, what to do in which scenarios. So please check out her resource, and we can post the link to the Google Doc. And so Mina's done that now. Next slide. I also, you know, we're obviously very confused, but so are our patients. And so we've put together this guidance called confusedaboutcovid.ca. So you can just type that into your website, confusedaboutcovid.ca, and we have 6 different resources to start. And they actually walk people through some of these same questions that we're getting from you guys now, even in the chat. And I would just argue that they're a great resource for patients, but they're actually also a great resource for you, because we've worked really hard to align them. And thanks to Dan for his help with that, with the Ministry of Health guidance, and simplify it so that it's visually like clear. Next slide. So I think I'll just highlight a couple of the key resources. So one is this: I'm not feeling well, what should I do? And so, of course, if you have symptoms, you should assume you have COVID, regardless if you don't need a test for the most part, and we'll make that clear here. And yes, they need to self-isolate, and we've got that, you know, who's for 5, who's for 10, who's for 20. And then many of you are asking these questions about the household, which I think I bungled up in trying to summarize. But basically, you know, if you have symptoms, everyone in your household has to isolate while you're isolating, and the amount you're isolating relates to, you know, whether you're vaccinated and your age, per that chart that you see there. And then if someone, you can stop isolating when your isolation period is done per that chart. But if somebody else in your household then develops symptoms, they need to follow that chart and restart their counting. So we try and clarify some of those most common questions. Next slide. I think the next really great resource is the one around contacts and close contacts. So again, this is really tricky. How do you define a close contact? And then how long should those close contacts be isolating for? And so we've really tried to simplify it here. You know, they have to isolate if they have symptoms, if they live with the person, or if they don't live with the person but have fewer than 2 doses of a COVID vaccine or a very weak immune system. And so we've simplified things and tried to make it visually clear for your patients, so you can just encourage the self-management and self-contact management and case management. Next slide. I think one of the most important, though, is really this: when should I call a doctor? Because we want our patients to be able to let us know if they have symptoms and they're one of those groups in particular that may need more monitoring, or that may qualify for treatments. And many of our patients don't realize that they may qualify for treatments or need more monitoring. So we've tried to make it very clear. I'm just showing the first 2 pages of this handout, but you can see we've got that list on the second page. And that list really aligns with what the Ontario Science Table guidance is. And so again, for you, even, it's a simplified way of keeping in your head, who are those people that we should have call us? In general, it's people who are over 60, people who are over 50 and Indigenous, or people who are over 50 and had fewer than 2 doses of vaccine and a few other things, or who are immunocompromised. So next slide. And then this is the 3rd and 4th page around when to call 911. Of course, we don't want them to go to the emerge if they don't need to, but some people will need to. And in particular, I think people have questions about kids. Next slide. And then, we've been talking about vaccines, and Allison, of course, has made the case for why we need to do better for 3rd doses. I think there have also been some questions about 4th doses, and maybe I'll turn it to you, Allison or Dan to speak about the evidence for fourth doses, but I'm just going to leave the slide up here, which does show which people in general are going to be eligible for a fourth dose of the COVID vaccine. In general, this is 3 months after their third dose. So I'm going to turn it to you, Dan or Allison. And all of these screenshots are just taken directly from the handouts, which are at confusedaboutcovid.ca.
Yeah. So there's new data out of Israel. Again, science by press conference. That suggests that in healthcare workers, they've been doing a pilot in healthcare workers of fourth doses. So for healthcare workers, this would be a fourth dose from Israel about 5 months after a healthcare worker's third dose. And what Julie Rajvrokov, who's a perfectly solid scientist, said was that they do get some antibody response, but it's not substantial, and it doesn't seem to be providing a lot of protection against Omicron. And so that's really useful to know that we're, that we're not seriously thinking about fourth doses for young, healthy adults at the moment. It does not apply to, in my view, to two groups of people. Certainly immunocompromised people, we know that people who are seriously immunocompromised do not respond as well, and they get substantial increases in antibody and increases in the proportion who respond and get some protection with additional doses. So fourth doses for immunocompromised people are a completely different ballgame. Fourth doses for long-term care homes is our second category. I think our second categories of people are people on dialysis and people who live in long-term care. So they're the people who generally respond, but respond at much lower levels than younger, healthier people. And dialysis patients and people in long-term care may get a really substantial boost from their fourth dose. If you look at the data we have for long-term care residents, the response that long-term care residents get to their third dose is approximately equal to what younger, healthier people get to their second dose. So it's reasonable to suppose that a fourth dose is going to move them up to something like a third dose. But we're still waiting for data, a couple of weeks from now, we'll have the first data on response in long-term care to fourth doses. We'll have more data on whether people who get their fourth doses in long-term care are better protected, and whether outbreaks are terminated earlier or less likely to start if we get fourth doses to home. So those two groups of people, I think there's still some uncertainty in different countries, and we're working on it. But I think the evidence out of Israel suggests that we're not moving on fourth doses for the general population anytime soon. Maybe sadly the next variant, but not with Omicron and not in the next couple of months.
Thanks, Allison. Brian, I think we can end slides, and I'm just going to ask you a follow-up question that's been out there quite a bit, Allison, is how about vaccination, third doses for teens, those 12 to 17? Any news on when or if that's going to be approved? I don't know, you, Allison, or you, Dan, if you're able to answer that.
So my answer is I don't know. I do not think we have seen evidence that third doses are a benefit for 12 to 17-year-olds. And although, myocarditis is less common with third doses, it's still something to worry about in teenagers. So I think what we're waiting for is some evidence that teenagers need a third dose to be protected against serious illness. And as long as we don't have that, and there's a lot of stuff passing me by these days. So maybe there's something out there I don't know about, but I think we haven't seen it yet.
Noah Ivers did write to me to let me know that he thinks that NACI recommendation is going to be coming shortly on this, and Dan is nodding his head. So hopefully we'll be hearing soon about that. I think the other question that seems to be coming up quite a bit is just how, once somebody has Omicron, we talked about whether they need to isolate again, but how long are they immune for? And kind of what are some of those implications around what they can do related to how long they're immune for? I mean, I think there were different questions about, can they now like not do the rapid antigen screening for workplaces because they've had Omicron? You know, do they still need to get I guess another one that comes up, do they still need to get a second dose or a third dose? So I wonder if you're able, Allison or Dan, to speak to that.
So I'll be happy to walk out on this thin ice. I think, you know, I think firstly, it's relative, right? So immediately post Omicron, you're very unlikely to get 2 Omicron infections in, you know, within a month, right? The longer you go past an infection, that's the same as the longer you go past a vaccine dose, the greater the risk of reinfection is. So I don't think there's an absolute line you can draw. And I think it is, you know, there is a certain element of we're in this together, and whether I've been lucky enough to get my 3rd dose early because I'm a healthcare worker, or whether I've just gotten through an Omicron infection and been lucky enough not to have it severe, I still have a responsibility as a Canadian to be following public health guidelines and doing what other people are doing. And you know, so you go to a party and everybody says they've just had Omicron. Do you know that? You know, is that really, how sensible a thing is that to do? So I think we need to try to hit that balance where all of us are doing our best to follow public health guidance under any circumstances. At the same time, you know, there is some element of, yes, if you just had Omicron, you should rightly feel a little bit more comfortable about what you can do, and where you can go for a month or 2. And I think, you know, one of the things that I do think we have to deal with in Canada, you know, it hasn't been an issue until Omicron because so few people have had infections that, you know, public health guidance thinking about what you get from an infection versus what you get from a vaccine dose wasn't important. But now that we've had, you know, we're going to have 15, 20, maybe even 30% of people infected with Omicron by the time we get through this wave, we are going to have to start to talk about what you get out of Omicron versus what you get out of a vaccine, and what it means. Similarly, you know, pre-Omicron, good evidence that getting the vaccine doses that were recommended increased your protection, even if you had COVID. Okay, so we had really good evidence to say you've had COVID, you still need your vaccine doses. We, of course, we don't have that with Omicron yet. Okay, we've only had Omicron for 2 months. You can't have everything all at once. So we're going to have to re-ask that question with Omicron. I think for the moment, we're going to stick with get your vaccine doses because they're not going to harm post-Omicron and they'll probably help. But people will be looking for that data to continue to support getting your boosters post-Omicron. In the absence, you know, I think it is likely enough that staying on track with your boosters, even if you've had Omicron, is going to make you better off, and people should continue to get their vaccines even if they've had Omicron.
I'll just quickly add, Tara, to the question about first regular screening testing. That is addressed in the most updated version of the guidance. You should not go back to regular screening for at least 30 days after you're positive.
Okay, thanks. And, you know, I should also mention that when we've been talking about the isolation guidance, and I just posted the confusedaboutcovid.ca, that most of that related to people not working at highest risk settings. So that, and the guidance for isolation for those in highest risk settings is very different, and they should, and maybe Dan, did you want to speak to that just briefly here?
Sure. I mean, essentially it's tighter for everybody in highest risk settings. So obviously we know, and to Allison's point before, about, you know, the risk of continuing to spread after the 5-day mark versus the 10-day mark. So in terms of the highest risk settings, which is really, it's places where the people who are at the highest risk of severe outcomes will be. It's hospitals, congregate settings with vulnerable individuals. Because of the risk of severe disease in that group, that's where the longer period is maintained. So it's still 10 days for any case. It's 10 days for any contact before returning. Again, other than what was mentioned around critical staffing shortages in the case where care will be compromised if someone's not able to return. And regarding those, there's very clear differentiation of the lowest risk way to get people back in earlier.
Thanks. So I'm going to turn it back to the slides to just go over a few last things. Brian, if you can bring those slides back up. I wanted to just share, so we'll go to the next slide. And this, Allison already talked about the booster coverage in general. Next slide. But I wanted to just share also that in particular, when we're thinking about third doses, there are some priority populations who really are being left behind from third doses. And in particular, I'm just going to focus here in on pregnant people who are at higher risk of hospitalization and severe outcomes if they do get COVID. And it's so important. We know that they get their first and second dose, but also their third dose. And unfortunately, we see that only 17% have. We can also see up here that in this slide that we can also do a lot better when it comes to people who are immunocompromised. Next slide. But I wanted to, in terms of pregnancy, there's this an excellent handout that the provincial group has put together. And Mina can put that in the chat, and encourage you to share it with your pregnant people in your practice. Next slide. And then I think the other piece is that we all still have a lot of work to do to have conversations with the parents of children 5 to 11, who unfortunately we're still at about a 50% vaccination rate of kids 5 to 11. I think many of us had hoped would be in a different place right now. We can see that it really varies by public health unit, and you'll be able to see these slides to locate where you are. But we know that family doctors have a huge role here in counseling and also administering the vaccine if you can. Next slide. Next slide. And I'll just going to actually just turn it over now to you, Liz, just for some closing remarks.
Yeah, thanks, Tara. And maybe I'll just mention that there's a plan for the 5 to 11 for a real blitz around pushing that age group. We're only at, I think, just over 50% for first doses. So just that will come. You'll see that being pushed out through the ministry and other avenues. So great for all of us to lean into those efforts, as well as the boosters, as you've mentioned, particularly for those at highest risk. And maybe I'll just take a moment. I'm really so grateful to Elaine and to Dan and to Allison. And one of the things in my role is I get this sort of 10,000 foot view, and I hear from so many of you. And it's really, for me, become a pattern that I've seen that it feels like we have to continually cross these bridges, through this pandemic. And on one side, and I felt this way in December, and many of you were writing me and telling me you felt the same, this sort of a bit of grief. Are we really going through this again? And some anger and some despair. And that's on one side of this bridge. And I just want to remind us that we cross over this bridge together, including in the work that we do collectively on these calls, and all the work that each of you are doing in your practices. And on the other side, we're not in the same place. We are advancing, and not only on the competence side, but I think particularly, Allison, on the pieces that you just talked about on the wisdom side of being able to say, like, this is complicated and we are balancing risks, and there are trade-offs. And it's, that all of us are being expected as family doctors to become experts at risk assessment as well. But that enables us then to be prepared for the next bridge that we will cross over together. So, and the other thing I think as family doctors is that the great privilege, but the responsibility we have of bringing our patients across this bridge as well. And, I really want to call that out, because it's hard work that we have done over and over and over again over the pandemic. So, I think gathering as a community here, or this is about practicing well, which is another place to gather in community with other family doctors, focusing around addictions and chronic pain. And then we have our FMS conference that's coming up. I think there's another slide on that that's coming up very shortly, and it's going to be excellent. So a lot of live sections. Yeah, if you go to the next slide. We have live sessions. It will be on demand. We have great speakers, lots of things about Omicron, but much that is not about Omicron, and is really all the other work that we're continuing to do in our practices. So really just want to honor all of you on the other side for the work that you're doing, and how critical it is from all corners of this province in terms of keeping people safe at home, and just making sure, you may know the other job that I have is around physician wellness, and how critical it is for us. It's exhausting work to just make sure you're taking that time and finding connection and finding some tranquility and some quiet space as you try to cross these bridges over and over again and make sense of what's going on. So
Thanks
I will
so much.
hand back to you, Tara.
Thanks. So I'm just going to close it out now, just to say that next slide, we're going to regroup in 2 weeks. And as always, we really value your evaluations. Let us know what you liked about this session. Let us know what topics you want covered for our next session, or if you have ideas for speakers. So please do fill in that evaluation form, and it helps to guide our planning in terms of that next session. And again, our full recording will be made available on our website, usually by the end of day, together with all of the slides. I know some of you wanted to see some of those slides for longer, and we skipped through them quickly just because of the degree of content. So you'll have the time to just go over them on your own. So thanks to our panelists today, Dr. Elaine Ma, Dr. Allison McGeer, and Dr. Daniel Warshafsky, not just for coming today, but also all the incredible work that they've been doing to lead us during this difficult time. And thanks to David Kaplan and Liz Muggah, my co-hosts. Together, all of the panelists and co-hosts have answered so many of your questions, I know, either through typing and in the live discussion. I know that there are also many more questions, and I'm sorry that we weren't able to get to all of them, but we will do a summary of a Q&A that we send to you with the post session as well, and that will also be posted to our website. That does take a few days to assemble, though. And then finally, thanks to you for all of the work that you continue to do in your offices and elsewhere to help get us through this inordinately difficult winter that I don't think any of us were expecting. So thank you, and I hope you get some rest this weekend. Stay safe, stay well.